Good morning, everyone. Welcome to the RenovoRx RenovoTAMP Fireside Chat. Joining us today from the company is Shaun Bagai, Chief Executive Officer, and Michael Pishvaian, Director of Gastrointestinal, Developmental Therapeutics, and Clinical Research Programs for the Johns Hopkins Kimmel Cancer Center. Dr. Pishvaian is also Study Chair for RenovoRx's Phase 3 TIGeR-PaC clinical study. This morning, we're going to be covering the challenges faced today in pancreatic cancer treatment, and we will be providing a deeper understanding of the RenovoRx Trans-Arterial Micro-Perfusion therapy platform. At the conclusion of our call, we'll have a live Q&A. Please note this call is being recorded today, Tuesday, June 21st, 2022, and will be available for replay at renovorx.com. Before we begin, I'm going to review the company's safe harbor statement. Listeners are reminded that certain matters discussed in today's webinar or answers that may be given to questions asked could constitute forward-looking statements under the safe harbor provisions of the Private Securities Litigation Reform Act of 1995. These statements are based on current expectations, and actual results may differ materially from those expectations. We refer you to RenovoRx's filings with the Securities and Exchange Commission, including its quarterly report on Form 10-Q, which identifies important risks that could cause actual results to differ materially from those contained in its projections or forward-looking statements. The company disclaims any intent or obligation to update any forward-looking statements as a result of developments occurring after today's webinar. Please submit your questions via the chat function of today's webinar. We'll do our best to get to each of your questions within the time frame allotted for today's call. With that, I'd like to give a warm welcome to Shaun, CEO of RenovoRx. Shaun, good morning. The floor is yours.
Good morning, Vulture. Thank you for joining, and Dr. Pishvaian, thank you for joining as well. The next slide, please. So we're here to talk about the RenovoTAMP platform and its place currently in pancreatic cancer with a deeper dive than we've done before. RenovoTAMP is our therapy platform of trans-arterial micro-perfusion, and we'll highlight the clinical development program for RenovoGem, which is the drug-device combination of intra-arterial gemcitabine plus the RenovoCath delivery system. And it's important to notice that this is a drug-device combination regulated as a new drug product with orphan drug protection, and we'll capitalize or highlight on the potential for the economics of our new branded oncology drug product. Next slide. So to highlight, and you can flip through these, we're in the middle of a phase 3 clinical trial for RenovoGem. Again, this is intra-arterial gemcitabine delivered through our FDA-cleared RenovoCath delivery system. We published phase 1 and 2, or phase 1/2, and observational registry trial data that has demonstrated efficacy signals that Dr. Pishvaian will take a deeper dive into. And we expect from a major upcoming milestone, the interim analysis of our phase 3 trial towards the end of this year, beginning of next year. If you look at the current issues with systemic chemotherapy and pancreatic cancer treatment, it's really the side effect profile that's causing an issue. We simply can't get enough drug into the tumor that the body can handle. The goal of our therapy platform is to decrease the side effects and increase tumor penetration, which would hopefully result in better efficacy. Our novel therapy platform, RenovoTAMP, is potentially compatible with multiple small chemotherapeutic drugs, but today we'll focus on the use of gemcitabine or RenovoGem for the treatment of pancreatic cancer. While that therapy platform and their first product candidate is applicable to many solid tumors, if you look at the initial indications of pancreatic cancer, which is a $1 billion market opportunity, and cholangiocarcinoma, our RenovoGem product could also be applied to other solid tumors, and I'll go over some more pipeline details towards the end of the talk. What's interesting about the platform itself is that while we're using existing molecules, we actually have several layers of protection from competition. I'll go into more details later on the orphan drug protection, what that provides us, and our several patents indicated as well. While Dr. Pishvaian will dive deeper into the current state of pancreatic cancer, I just want to touch on our first two indications. Of course, we're well into the phase 3 of pancreatic cancer, which is one of the deadliest cancers with very poor outcomes. And there hasn't been a lot of commercial opportunity here in terms of success. The last major drug approved for the treatment of pancreatic cancer was the addition of Abraxane to the gemcitabine backbone back in 2013, which was based on only an 8-week survival benefit. And as Dr. Pishvaian will explore more deeply, locally advanced pancreatic cancer has approximately a 12 to 15-month median survival. Next slide. For cholangiocarcinomas, our second indication, that's also known as bile duct cancer, very similar to pancreatic cancer with a poor prognosis, and current standard of care is not well defined due to the issues with penetration and systemic toxicities. Having said that, gemcitabine is a common backbone for this treatment as well. So it makes an excellent target for a RenovoGem platform. Next slide. Just to touch on the market opportunity here, as mentioned, this is an orphan drug product, which gives us 7 years of marketing exclusivity post-approval. We will seek an NDA or new drug approval for RenovoGem. With J-code reimbursement, we anticipate about $1 billion market opportunity. If you look at the cost of new oncology drug pricing, which is about $150,000 per treatment year. This is baseline potential market, and we will do a formal pricing analysis at the conclusion of our phase 3 to see what the right pricing is for this based on also other things in the trial that we discover, like the treatment of side effects, hospital admissions, revisits, and we can find a fair pricing that's also accessible to our therapy platform. So with this, I'll turn over to Dr. Pishvaian to discuss the current state of pancreatic cancer, dive deeper into the current treatment modalities for locally advanced pancreatic cancer, a little more detail on our data and our therapy platform to get from here.
Thank you, Shaun, and thanks for giving me this opportunity to speak here today. So pancreatic cancer is a disease that is near and dear to my heart. It's my primary focus in my practice, and it's been a very difficult disease to focus on and treat because it's actually one of the few cancer types that's increasing in incidence, and within the next few years will become the second leading cause of cancer-related death. There's over 60,000 patients a year in the United States who are diagnosed with pancreatic cancer, leading to nearly 50,000 deaths per year. And unfortunately, as many of you may have heard, pancreatic cancer is a disease that is often inoperable. About more than 50% of patients are identified with metastatic disease, meaning disease that has spread outside of the pancreas from the outset. But in addition, about 30 to 40% of patients have localized cancers that may or may not be able to be rendered operable. And if they're not rendered operable, then those are also incurable diseases. Next slide, please. Because of this, pancreatic cancer has the lowest survival rate of any major solid organ cancer, with the overall survival rates of just under 10%. Pancreatic cancer accounts for 3% of all new cancer cases, but unfortunately is the cause of 8% of all cancer-related deaths. And as I said, will soon be the second leading cause of cancer-related death in the United States. Now, as you see in the bar graph there, patients who have localized cancer do have about a 40% chance of cure, but even those who have potentially operable cancers, their cancers will often recur. But that's unfortunately just a fraction of the patients because 80 to 90% of patients have either regional or metastatic disease from the outset. Next slide. So as I mentioned, the only real path to cure is surgery, and we do cure a small percentage of patients, a little under 10%. But at diagnosis, only 10 to 20% of patients have operable disease, 25 to 30% are locally advanced and inoperable, and 55% roughly are metastatic. But even those who are operated on, the cure rate only is about 10% because of those that are recurrent, of those that are operated on, about 60% will ultimately recur. Next slide. So the decision for determining or defining localized pancreatic cancer really is all about the local vasculature of the tumor and how safely a surgeon can remove the tumor without compromising that local vasculature, because particularly the arterial vasculature is critical for feeding the normal healthy organs of the GI tract. And so these definitions were set in place maybe 10 years ago. There is some gray area to defining borderline resectable versus locally advanced, but these are generally the agreed upon NCCN guidelines, where in a resectable cancer, there's absolutely no arterial tumor contact at all. On the other end of the spectrum, for a locally advanced unresectable tumor, there's solid contact with the critical arteries, the SMA or the superior mesenteric artery, or with the celiac artery, of greater than 100 degrees, 180 degrees. So basically the tumor wraps around the artery at least 180 degrees. Often it completely wraps around it. And then those that are borderline resectable, which really only represent about 5% of all pancreatic cancers, the tumor is just sitting up against or abutting those critical arteries. And that really is, again, only a small percentage of patients. Next slide. The current therapy guidelines for locally advanced disease really mirror the current therapy guidelines for advanced disease because there hasn't necessarily been anything proven or disproven in the locally advanced setting. And the two regimens that we have access to are modified FOLFIRINOX and gemcitabine plus nab-paclitaxel. Nab-paclitaxel is also called Abraxane. We can use gemcitabine cisplatin for patients who have known BRCA1, BRCA2, or PALB2 mutations, and which represents about 5 to 7% of patients. For patients who have a poor performance status, just single agent gemcitabine could be used, but this is something that's actually not very often used because the toxicities of gem-nab-paclitaxel are not all that different from single agent gemcitabine. And it's important to note that single agent gemcitabine by itself, systemically given, has been proven to be inferior to either FOLFIRINOX or gem-nab-paclitaxel. Next slide, please. So one of the reasons that people often ask, why is pancreatic cancer so difficult to treat? Well, there's a number of answers to that, but one of them certainly is the fact that these are not very vascular tumors. When you do a cross-section of these tumors, there's really just a very dispersed set of cancer cells. There's a tremendous amount of tumor connective tissue, what we call stroma. And within that stroma, there aren't actually a whole lot of blood vessels. And so these tumors do not get a ton of vascularity. And so drugs and therapies do not get to the tumor cells very efficiently. So because of that, it's difficult to be able to get to the tumors intra-arterially. And so you really want to sort of find the main feeder vessels when you're trying to think about doing any kind of intra-arterial therapy. Next slide. So this is what a typical hypervascular tumor, such as those that arise in the liver. The liver is a very vascular organ, and the tumors, whether they're the primary liver cancer that started in the liver or metastases that have spread to the liver, these tumors in the liver often have a fairly rich blood supply. And so these tumors can be actually targeted and accessed with some of the local current intra-arterial therapies. Whereas the less vascularized tumors, such as pancreatic cancer, you really just have a main feeder vessel and then very, very small capillaries that branch off of that. Next slide. Talking about emerging modalities in locally advanced pancreatic cancer, as I mentioned, there's no real definitive standard except for the chemotherapies that we use for metastatic disease and applied of locally advanced disease. But locally advanced pancreatic cancer often causes a great deal of symptoms, and something I coach my patients through, that the pain and the weight loss and the loss of appetite that they experience are often due to the cancer itself. And local control isn't always achieved with chemotherapy as well as is control of the metastatic spots. We often talk about the fact that the local tumor, for what reasons that we don't understand, doesn't tend to shrink in response to chemotherapy nearly as well as do tumor deposits that have spread to other organs. So really kind of controlling local disease can be challenging. Next slide. One of the ways that's currently being investigated to approach local control are through these tumor treatment fields, which are used as an anti-mitotic therapy. This is a paradigm by which the cells are challenged with an alternating electric field to disrupt the charged particles during the course of mitosis, and this, in theory, leads to cell death. This is actually an improved paradigm for glioblastoma or brain tumors, and is being investigated for abdominal tumors, including pancreatic cancer. Next slide. So the challenge with the delivery of these tumor treatment fields is that you actually need to be able to give or deliver this alternating current that you see in that image with the gentleman with the patch on his abdomen. You need to be able to deliver these alternating tumor fields on a constant basis to be able to catch the cells that are in mitosis, because cancer cells aren't constantly dividing, and they are dividing at different times during the day. And so you need to deliver this field constantly, 18 hours a day, including, during all of their activities. However, there is preclinical evidence that combining these tumor treatment fields with chemotherapy, particularly gemcitabine, can increase the efficacy in reducing tumor volume. Next slide. Another approach to trying to treat locally advanced pancreatic cancer is to use an agent that targets specifically that stroma, that connective tissue that I mentioned is richly surrounding the cancer cells. And a drug called pamrevlumab, FG3019, is a drug that inhibits this connective tissue growth factor. And in a locally advanced study, phase 1, phase 2 trial, comparing pamrevlumab versus plus gem-nab-paclitaxel versus gem-nab-paclitaxel alone, there was some initial signal of potential benefit, but the primary endpoint of median overall survival was not met. And so the company has actually expanded this into an ongoing phase 3 trial. Next slide. And then, of course, we have the intra-arterial gemcitabine using the RenovoRx Trans-Arterial Micro-Perfusion methodology. Next slide. And the idea here is to be able to deliver chemotherapy more effectively to the tumor directly. So we talked a lot about the hypovascularity of these tumors, and when the effective chemotherapy concentration within these tumors delivered intravenously, so basically through the arm or through a port, there's not a whole lot of concentration of chemotherapy that gets to these tumors. But the RenovoRx system, oops, sorry, go back one slide. Yep, can actually deliver a much higher concentration by increasing the intra-arterial pressure and forcing the drug to be able to get to the tumor effectively. Next slide. So using this RenovoTAMP methodology in a pig model, you can see that in this pig model, the tissue concentration within the tumor is logarithmically two log levels higher within the tumor itself. So the gemcitabine is getting there much more effectively when it's delivered to the tumor under pressure. Next slide. How do you know what artery to access? Well, this is where actually having vascular interventional radiologists and vascular interventional cardiologists guiding this program has been really helpful, because you can use CT imaging, which is the standard imaging that we will use for all of our pancreatic cancer patients anyway, but you can use CT imaging to be able to visualize the vasculature and to be able to know where the balloons need to lie to be able to get drug to the tumor effectively. Next slide. So going through the clinical data. Next slide. So there was an RR1 dose escalation safety study just trying to establish the safety of this methodology. And for this, 20 patients were enrolled and they experienced 101 treatments. And then there was an RR2 observational registry that was opened up that included 25 patients and received 96 treatments. And both of these studies have been completed. Next slide. So in the phase 1 and also the observational registry studies, altogether there were 43 patients treated between the two studies. The average age of the patients was 70 years, which is typical for pancreatic cancer. These patients were generally pre-treated for their pancreatic cancer, and the median gemcitabine dose that was delivered was 1,000 milligrams per meter squared, which, by the way, is the same dose that we use intravenously, systemically, for these patients. So you're essentially giving a systemic level dose, but under pressure to a very smaller target area. Next slide. So on average, the patients each reached 4 intra-arterial treatments. The range was 1 to 14 treatments, and 13 of the 43 patients completed all 8 planned treatments. The reasons for discontinuation of intra-arterial therapy included tumor progression, the patient or physician preference, There were serious adverse events and things that were learned during the course of the study in 6 patients. Next slide. But there was some promising initial results. And for the patients between the phase 1 and the registry study who had received intraarterial therapy and also had received prior radiation therapy, which was 10 patients, the median overall survival was 28 months, which is significantly longer than we typically see with chemotherapy alone, including gemcitabine or gemcitabine plus radiation, where we typically quote survival rates of about 12 to 15 months for patients that are only getting intravenous therapy. So this was a historical control comparison. We wanted to prove the benefit of the intraarterial therapy in a phase 3 trial. Next slide. So this led to the TIGeR-PaC study. Next slide. So this is an ongoing study of transarterial gemcitabine versus continuation of IV gemcitabine and nab-paclitaxel following radiation therapy for patients with locally advanced pancreatic cancer. And really the primary endpoint is efficacy, is survival, to see if this system is actually improving outcomes for patients with pancreatic cancer. Next slide. As I mentioned, the primary objective is overall survival from the time of randomization, and the randomization is the intraarterial gemcitabine versus continuation of IV gem nab-paclitaxel. There are a number of key secondary endpoints, including progression-free survival and objective response rate, but also very importantly, health-related quality of life during the period that the patients are getting the intraarterial therapy versus continuation of IV gem nab-pac. Next slide. So the study overview, this RenovoCath system has been FDA cleared, and so can be used during the course of the study. The gemcitabine indication is consistent with the IV administration. As I mentioned earlier, the dose is the same, and really the idea is to try and get the intraarterial therapy effectively to the locally advanced pancreatic cancer tumors and to try and improve outcomes. The sample size for the study is 200 patients who are randomized to treatment. Next slide. So this is the study design. We actually spent a lot of time thinking this through, and we wanted to be able to get patients who have already had some induction treatment. So all patients will receive IV gemcitabine plus nab-paclitaxel or Abraxane. And then they receive radiation therapy because it was shown to be critical in the registry studies to be able to effectively enhance the efficacy of the intraarterial therapy. And then they get 1 additional month of gemcitabine nab-paclitaxel. Next slide. Then the patients are randomized to continue gem nab-paclitaxel or Abraxane, which would be the absolute standard of care. It's what I do with my patients outside of the context of the clinical trial. And then in parallel, another group of patients is randomized to receive 4 months of 8 biweekly treatments of intraarterial chemotherapy. So you see that we're maintaining an even comparison group with similar timeframes of 4 months for both of those groups. After patients have had either continuation of IV gem nab-paclitaxel or the intraarterial therapy, then they go into an observational period where they continue therapy, maintenance therapy, until disease progression. Next slide. Now, and there will be a pre-planned interim analysis in Q4 this year or Q1 next year, but the ultimate endpoint is survival outcome, overall survival outcome. Next slide. So the endpoint analysis will be from the first time of randomization, which means that not from the time the patients start their chemotherapy, but after the 4 months of chemotherapy when they're randomized to receive intraarterial therapy or the continuation of IV chemotherapy, giving us the most efficient look at the benefit of the intraarterial chemotherapy. The interim analysis, as I mentioned, after Q4 22 or Q1 23, will be based on 65 events, which unfortunately are patient deaths. The data monitoring committee at that point can stop the study based on efficacy or futility, and or the data monitoring committee can increase the sample size if needed. There has been strong enrollment for the past 3 years, and actually the enrollment rate continued to be the same despite COVID, and we're hoping to be able to complete this study in 2023. Next slide. All right, Shaun, I'll pass it off to you for the pipeline.
So thank you so much, Dr. Pishvaian. So just to wrap up, just want to touch on what's next for RenovoGem and RenovoRx. So as mentioned, the platform itself is this delivery of chemotherapy across the vessel wall, our trans-arterial micro-perfusion, and our first product candidate is RenovoGem, which is the combination of intra-arterial gemcitabine plus our delivery system in a drug device combination. Next slide, please. For RenovoGem specifically, this is the potential pipeline. So as mentioned, we're in the middle of a phase 3 trial with interim readout towards the end of this year. We anticipate launching, as I touched on earlier, our second indication, which is cholangiocarcinoma or bile duct cancer. We're wrapping up the design of that with anticipation of launch this year. Beyond that, we're looking at what other tumors have been treated systemically by gemcitabine that could benefit from our delivery system. So in non-small cell lung cancer, uterine tumors, and glioblastoma, this is very common. We have done some early animal studies in lung tissue. In fact, the panel that Dr. Pishvaian shared earlier was actually in lung tissue of a pig artery, demonstrated a 100-fold increase in tissue concentration. So we're looking to see what subsets might benefit from our RenovoTAMP platform. Next slide. Focusing on these diseases, there are about 350,000 total patients diagnosed per year. If you look at the locally advanced target that we're looking at is about 125,000 patients per year. These are all potentials for gemcitabine and RenovoGem. Next slide. What's of course interesting about the platform itself is this could be applicable to other locally advanced tumors with other molecules as well. So we're not limited to just gemcitabine, although this is our first target and product candidate. We could be compatible with other small molecule drugs as long as they're small enough to push them across the vessel wall. Next slide. From an exclusivity standpoint, as gemcitabine has been around for decades and several manufacturers, we can capitalize on orphan exclusivity. So just to touch on that for a moment, with orphan drug protection for both pancreatic cancer and cholangiocarcinoma, the FDA provides us for 7 years of market exclusivity post-approval. Beyond the regulatory protection, we have several patents issued around the RenovoTAMP platform itself, the radiation plus RenovoTAMP, the delivery system, the drug device combination. These are mostly in the US. We also have a patent issued in Europe with several patents pending in the US, Europe, and Asia. The gemcitabine drug itself, we're sourcing from one of many ANDA FDA holders. Next slide. So just to summarize, we have a de-risked and validated RenovoTAMP approach. The pancreatic cancer locally advanced haircut down market is about $1 billion market opportunity for our first product candidate and our first indication. We anticipate the next major milestone towards the end of this year to beginning of next year with the RenovoTAMP interim data analysis. From a cash perspective, we're well capitalized and capital efficient. Reported out last quarter with $13 million in cash. This will get us enough to get through the interim readout and launch for a second indication and well into the second quarter of next year. We have an experienced leadership team and board of directors. And just to touch up the upcoming catalysts, as I mentioned, the major ones are launch of our second indication and the interim readout of our phase 3. And we'll continue following that with building out the pipeline, finishing the study and final data analysis. Thank you for your time.
Thank you, Shaun. Thank you, Dr. Pishvaian. Appreciate it. As a reminder to our listeners, we've received several questions already, but you can submit your questions via the Q&A function of today's webinar. Our first question is regarding patients. Dr. Pishvaian, we have our audience asking, how have patients tolerated the therapy thus far, and what has the side effect profile been?
So thanks for the question. One of the goals of the intra-arterial delivery system would be to decrease systemic doses of chemotherapy. And that actually has been observed. There is still some systemic dose that gets into the vasculature, but actually patients definitely tolerate it better than getting standard chemotherapy. We're hoping to be able to prove that on a data basis with the health-related quality of life analyses. But at least in the experience from the registry studies, patients do seem to tolerate the treatment very well. As a medical oncologist, not an interventionalist, I was concerned about the repeated intra-arterial delivery for these patients. But actually what we've learned is that patients really don't mind that procedure. And they do get patients with cancer come in usually weekly to get stuck in the vein to be able to get treatment. And they see that really as no different from the way they get their standard chemotherapy.
Thank you. We have another about competition, Shaun. What does the competitive landscape look like for this indication and the rest of your pipeline?
Thank you for the question. So really our biggest competition is standard of care, systemic chemotherapy, which Dr. Pishvaian has gone over the shortcomings there. Beyond that, Dr. Pishvaian did touch on the NovoCure therapy of tumor treating fields. They are in clinical research in locally advanced pancreatic cancer, as they've demonstrated success in glioblastoma. Dr. Pishvaian did highlight some of the shortcomings in terms of patients having to wear this vest hooked up to a generator. And what's interesting is actually NovoCure is, I'd say, several years ahead of us with their first indication in glioblastoma, and has very successfully built a multi-billion-dollar company around targeting these niche and orphan patient populations. So if I look actually at NovoCure, it's more of an example of where we could go, and these technologies could be compatible. As you know, with pancreatic cancer, and Dr. Pishvaian can touch on this, it's a multi-specialty approach. So in terms of commercial competition, I don't see much coming down the pipeline, but there could be collaborative avenues there. And I think a better case of the story is the analogs of what this company could become with this platform. Dr. Pishvaian, if you want to expand on that.
No, I definitely have to concur that this is a pretty wide open field. You know, technically, the chemotherapies aren't even approved for locally advanced pancreatic cancer. We just apply them for metastatic disease. So the playing field is actually wide open. But there have been a lot of studies that have tried to make an impact on this disease in the locally advanced setting. And it really has to do with, the failings have to do with the fact that these locally advanced tumors, that the primary tumor is very difficult to get the right therapies to. And I see that all the time, where patients have metastatic disease, you give them chemotherapy, and the tumors in the liver or the lungs shrink significantly, but the tumor in the pancreas really doesn't change. It's just something we see all the time. And again, that's because we think that the chemotherapy is just not being very effectively delivered to the primary tumor, and this could be a game changer. Well, I'll stop there. I won't go off script. I was going to say that there's an ongoing discussion about whether we should be treating the primary tumors more effectively for patients with even metastatic pancreatic cancer, and we're exploring trials to try and tackle that because of the symptoms that come from the primary tumor. And so having more in the arsenal there would also be beneficial.
Great. And along those lines, speaking about the competitive landscape, Shaun, in the presentation, we do talk about the industry size. We allude to the fact that it's about $1 billion in total addressable market. Any other data there that you want to highlight?
Yeah, thank you for the question, Walter. And this goes on what Dr. Michael Pishvaian was alluding to, is we're focused on locally advanced pancreatic cancer. So that's that small niche of 20 to 30% of the patients. Beyond that, the desire for local control, even in other settings, we could expand this to beyond locally advanced. There's a big push for neoadjuvant chemotherapy on pre-treating even resectable disease. So localizing chemotherapy to control the primary tumor prior to surgery could be a place for additional research. Beyond that, and Dr. Pishvaian, you probably remember this research well coming from Georgetown, there are early studies on looking at localizing liver tumor mets with treatments and systemic gemcitabine for the metastases. Flipping that around, one could argue that a lot of these patients have a single liver met or a lung met that could be treated locally, and then we could also apply our technology to treat the primary tumor. So beyond locally advanced pancreatic cancer, which is our current clinical focus, there's an opportunity to expand into other areas in pancreatic cancer to further reach more of that 60,000 patient volume.
Great. And we are getting a question about radiation. Shaun, I'll start with you, and Dr. Pishvaian, I'm sure you have thoughts. Why is radiation important for this therapy?
Yeah, thanks for the question, Walter. Yeah, Dr. Pishvaian, maybe you can give a little background on radiation, and I can dive into more details about our therapy if necessary.
Yeah, no, thanks for passing the baton. So radiation therapy in localized pancreatic cancer has been fraught with back and forth, sort of should we use it, should we not? And the studies that have been done thus far demonstrate no clear benefit with radiation therapy. But nevertheless, most of us, particularly the academic setting, we'll continue to use radiation therapy because we see the symptomatic benefit to patients. I think one of the challenges for radiation therapy in locally advanced pancreatic cancer is that we've really never understood the mechanisms or the why we're treating with these patients. We know that the radiation will kill the primary tumor, but we don't know what it's going to do overall to the patient's overall prognosis. In this case, it's actually being used for a very different purpose, which has been clearly demonstrated in the animal models, where the radiation therapy will actually increase the delivery of the chemotherapy delivered intraarterially to the tumor. So the radiation is actually acting as an adjunct, as a pre-treatment that's making the tumor even more susceptible to the intraarterial chemotherapy.
Great, thanks, Dr. Pishvaian. And just for us laymen, if you think, you can imagine we're forcing so much chemotherapy across the vessel wall and the tissue. There's a microvasculature that exists in the vessel wall and the tissue, where as you give this tidal wave, it can wash out some of the chemotherapy. So one of the theories here is by reducing that microvasculature with the radiation therapy, you have more staying power of the chemotherapy and potentially a better effect on the tumor itself.
Perfect. And it doesn't look like we have any further questions. Shaun, Dr. Pishvaian, any final thoughts?
Dr. Pishvaian?
I think that there's really a need for this patient population. Again, I treat primarily patients with pancreatic cancer, and I'm always looking to increase the armamentarium for how I treat these patients. And if this delivery system proves true, it could be really useful to be able to help these patients out, because they don't like being just on constant chemotherapy, and to be able to give them a break and still tackle a tumor effectively, it could be a really useful tool.
Thanks, Dr. Pishvaian. And with that, I'll close it. This always comes back to the patients. What we've seen, back to your earlier question about how patients are doing the therapy, a lot of these patients don't look like chemotherapy patients. I think, Dr. Pishvaian, you've seen the effect here is that by localizing the therapy, patients anecdotally have gotten back to their normal lives under this therapy, with a promise that this could be efficacious and extend that life. So we're coming up on interim analysis towards the end of this year, and we're looking forward to having a successful clinical development program to bring this to the clinic. So I thank everyone for joining. Dr. Pishvaian, thank you again for being such a part of this story, and looking forward to continuing to work with you.
Okay.
Thank you both for the presentation this morning, and thank you to our audience. As a reminder, this will be recorded and up on our website. And as always, please email us, RenovoRx@kcsa.com. We look forward to hearing from all of you. Thank you.
Thank you.